So today I'm here to share some of my experience in uveitis, and my learning objective with all you virtual friend is not exactly to teach how to define uveitis or how to classify uveitis. Rather, will be not rather than going to the ABCD of uveitis, let's start from PQRS. Is my screen being visible?
Yes, ma'am. Yes.
Okay. So the prevalence of uveitis varies in different countries, in different the prevalence is different, okay? And the complete ocular complication due to uveitis may vary from 10 to 15%, but in a developing country like ours, it is up to 25%. And when we evaluated what is the prevalence rate at our scenario, at our hospital, we found it to be 0.82%. Uveitis is very different from other ocular diseases because it's like a puzzle, it's like a wonder. You have to find the exact match for that puzzle to be solved. And the main puzzle is with its etiology. And this finding and fitting puzzle is the greatest task and the most needed task also, because if you can fit the puzzle, you can treat the disease according to the etiology and thereby decrease the recurrence and complication. That's why how to move forward towards solving this puzzle. For that, we need a proper classification. And since we know in uveitis the uveal tract is involved, and that tract is again made up for the three parts. That's why if we can identify which part of this uveal tract is involved, according to that we can reach a step close to its etiology. And this uveitis, as we know, can be caused by vast number of variable conditions. So these conditions can, some of this condition can be life threatening also. Like a uveitis could be manifestation of Wegener's granulomatosis or a manifestation of CNS lymphoma, which is a life threatening condition. Just looking at the cells in the eye, you might exactly be preventing such life threatening condition in that person. And moreover, we have to find the etiological agent for this disease so that you can minimize your treatment, you can give a targeted treatment. That's why a proper classification is needed. And this is the classification we have been following for the last around 2 decades, which is given by Sun. But recently, this classification has been upgraded. It is yet to come formally, but it has been upgraded and vasculitis has been added in posterior uveitis. Many of the times our ill disease patient, they are visiting in uveitis clinic or in the retina clinics. Now retinal vasculitis have been upgraded to the posterior uveitis and the new classification will soon be released. Now which part
Excuse
of
me, ma'am.
the, yes,
I guess we are going so fast. Can you little bit go slowly, ma'am?
okay, sure. Now, whether we are facing a case of anterior uveitis, intermediate or posterior uveitis, in fact, it depends upon the which blood ocular barrier is breached. Okay, if the breach is in the blood aqueous barrier, then this will lead to anterior uveitis. If the breach is in the blood retina barrier, then this will lead to intermediate uveitis or posterior uveitis. That's why it's a fight between your immune system and the blood ocular barrier. That's why which type or which classification of uveitis does it fit, that depends upon which ocular barrier is breached. Once there is breach in the ocular barrier and the eye is inflamed or the uveal tract is inflamed, it might present with a red eye, like at the top, or a white eye with the past feature of uveitis, or a white eye with some lesions at the back of the retina, at the back of the eye, that is in the retina. Now, how to evaluate this? It should be a very meticulous approach. That's why in a case of uveitis, you have to examine the patient head to toe. More than that, the priority should be given to the history or small history of contact with a pet or small history of contact with white moths or any disease in the body that can lead to a step close to your etiological diagnosis. Your history should be matched with your clinical findings. And in uveitis evaluation, the clinical findings does not fit just upon the eye. You have to look the patient in total. then you have to step forward to the investigations. You can't do all wide area of investigation and uh, just to identify the etiology. Your clinical manifestation, your pattern diagnosis is very important for a tailored investigation so that you can treat the patient accordingly. If you fail in any of the step, the problem is with the complication. There will be high chances of ocular morbidity and high chances of recurrence. That's why this cycle to in order to break this cycle, you have to do a meticulous history, a detailed clinical finding, a targeted investigations, then a targeted treatment. Now just look at this eye. This is just a manifestation, a manifestation in a person. Then how can you reach to the diagnosis? This was the posterior segment finding. Now to reach from the cornea to this to reach the etiology from this corneal or the aqueous finding to the retinal finding, you have to go step by step. That's why history plays a very important role in a case of in approaching a case of uveitis. And as we said, history of even loss of hair in your head or deformity of the toe of the patient, that is are very important. Some patients just might present with hearing loss. This could be case of VKH, travel history of patient staying abroad, history of sexual exposure. These all has to be borne in mind. Any pigmentation in the body or any let me make clear that anything, any finding in the hair or in the skin or in the bones or in any system of your body, that has to be documented. A patient might just give history of diarrhea. He might not feel important just to say the history of diarrhea with you, but this could be a case of uveitis due to Crohn's disease or due to ulcerative colitis. So when a patient of uveitis enters your room, you have to examine the patient in total. Just graying of hair in the eye, that could be a leading finding for you to reach to VKH or a SO, sympathetic ophthalmia case. If a patient is walking in your room with kyphosis, this could be case of ankylosing spondylitis or cervical spondylitis who could manifest with you in a form of anterior uveitis. Moreover, any rashes in any part of the body or in the limbs, along with this, also in the tongue or the oral cavity, we can't ignore the symptoms because these are the leading clues for us to reach towards the etiological diagnosis. And any chest symptom which have become more important in this today's context, this has to be borne in mind. Once you are done with a meticulous history taking, a wrap-up systemic examination, then only we are supposed to move towards the ocular manifestation. Many patients may present with pain, redness, photophobia, but these are more in common with the patients with anterior uveitis. The cases with intermediate uveitis, they may just present with floaters, and the patients with the posterior uveitis, they may present with the visual disturbances. Okay, the causes of decreased vision in uveitis could be because of lot of etiology. This could be because of the shift in the refractive error, a myopic shift because of the excavated lesion in the retina, or a hyperopic shift because of the edema in the macula or the Dick's edema. This can lead to decreased vision. Even the decreased vision could be because of the corneal edema, macular edema, Dick's edema, or any dense exudation occurring in the pupillary axis, or uveitis patient usually present with the myope pupil that can also lead to decreased vision, and secondary cataract or complicated cataract are very common in uveitis cases. So this could lead to the decreased vision. Many of the time, the uveitis patient, they get dispatched as with a diagnosis of conjunctivitis. But we have to cautiously look at the pattern of the congestion that the patient is presenting. The uveitis patient usually, in a case of acute anterior uveitis, they present with circumciliary congestion, but the conjunctivitis patient may not do so. We have to differentiate the pattern of congestion in both of them. After moving forward from conjunctiva to cornea, cornea is a very important tissue for us to look very cautiously to establish the cause of uveitis. The findings can be in all the 5 layers of cornea. There can be epithelial edema, there can be stromal infiltration like in case of viral uveitis, or the main finding may lie in endothelium. Endothelium, basically we can find the keratic precipitate, the pigments and the fibrins. We'll talk about this more detail in the coming slides. Now, as I told, in the endothelium, we are cautiously looking on the keratic precipitates, which are the inflammatory cells that are deposited in the corneal endothelium. They are classically supposed to be deposited in this arch triangle pattern, but this may not happen many of the times. If they are deposited diffusely, that's also a clue for us to reach or to keep in the differential diagnosis that the uveitis in this particular case could be because of sarcoid, Fuchs, or leakage. And we have to look whether it's a pigmented or a white fresh keratic precipitate. The size of keratic precipitate is a big concern for us. If they are large, greasy, of more than 1 millimeter size, these are the clues for mutton fat KPs. The mutton fat keratic precipitates are, in fact, a step leading towards the granulomatous etiology of this disease, so that we can squeeze out differential diagnosis from non-granulomatous to granulomatous etiology like tuberculosis, sarcoidosis, VKH, etc. Now, what are the advancements that have been made in the identification of this keratic precipitates? Earlier, it was based on the finding of slit lamp, but now we can demonstrate this keratic precipitate even in the endothelium using the anterior segment OCT. Even the cells and the keratic precipitates can be demonstrated. This is the anterior segment finding in one of our patient of Shapu. Here we could demonstrate these are the fine hairs of the moth that was present in a case of Shapu. So anterior segment OCT can help us in detecting any abnormality within the various layers of the cornea, and especially for the corneal endothelium keratic precipitates. What's new? There are specific patterns of micro details of keratic precipitates that can be identified by specular microscopy. Like this is the specific pattern for viral etiology of uveitis, and this one was for the ocular toxoplasmosis. So they have developed a specific micro-detail pattern of keratic precipitates in specular microscopy. Moreover, we are still in the corneal layer of the corneal layer to while evaluating a case of uveitis. The corneal thickness plays an important role in identifying whether the disease is still active or regressing in a case of especially acute anterior uveitis. We have already conducted study at our center, and we found that before treatment, the corneal thickness that was measured was significantly higher than compared with the thickness after the treatment. So this can be done with the bone serous instrument. Moreover, we can even do the corneal mapping or the topography. And this on the right hand side, this corneal topography is of a Shapu patient where it shows that the cornea was thickened. That's why we say that there are a lot of tools that are being added on for the better evaluation of cornea in a patient with uveitis, especially the anterior uveitis. Moving from cornea towards backward is the anterior chamber, where we especially look at the cells and the flares. The traditional grading that we have been adopting worldwide is the SUNS grading, where actually we need to count the cells in the brightest beam. Okay. Now, what is latest in this? Already in 2013, they have published paper saying that the anterior segment OCT can be used for the gradation of cells from 0 to +4. This is more accurate. In fact, they can quantify the number of cells using this anterior segment OCT. Moreover, recently they have added that this this is in fact in vitro. They can differentiate between the inflammatory cells and the blood cells using the spectroscopic anterior segment OCT. So these are the newer addition in evaluation of the cells in the anterior chamber. Now coming to the flare, yes, we look at how much aggregation of the protein is there in the anterior chamber with the help of gradation of the flare. But this can be done with the use of laser FLAROMETRY, where you can actually measure the pre-treatment flare and the post-treatment flare measurement can be done. And these are especially important for any case of uveitis and more importantly in a case of endophthalmitis, where actually you can see whether it's a treatment failure or treatment responding case. The flares are the earlier sign of a reactivation. That's why the quantification of flare will definitely help us to to reach a step close, whether it's an active case or a regressing treatment successful case. The cells may be so much dense that they may collect at the bottom, forming hypopyon. And these hypopyon are commonly seen in any case of anterior uveitis with severe inflammation, or more commonly in actually B27 uveitis, or in a case of Behçet's disease, endophthalmitis, Chapu, or in viral uveitis. Now, we have to cautiously look about the pattern of hypopyon. You can see in the picture at the top, there is a lot of flare. That's why the details of the iris and the lens is not clear in a patient with this hypopyon. And this is a clue that it is a case of actually B27 positive uveitis or a case of endophthalmitis. However, in the second picture, the hypopyon at the bottom is there, but relatively you can see the flare is less, making the iris more visible. This kind of hypopyon are particularly present in a case of Behçet's disease. That's why even the pattern of hypopyon are a clue towards your etiology. Sometimes this hypopyon can be misleading to you because they could be a case of pseudohypopyon, like in case of masculine syndromes leading like metastatic carcinoma or retinoblastoma. The evaluation or the etiological diagnosis in such case can be done easily with the help of anterior chamber tap. The anterior chamber tap can be done as a OPD procedure like this being done with Dr. Jyotirmay Biswas in his OPD setting, or better in OT setting, where you can take the small, even a drop of the aqueous fluid and then send it for the cytological examination and for the PCR. Let us have a look on this patient. This was a case of hypopyon in a girl of 8 years old who was not responding with any kind of steroids. And the sample of this patient was sent by Dr. Biswas for cytological examination, and then it was found that there were basophilic cohesive cells with hyperchromatic nucleus, and which in fact was a case of retinoblastoma, not a uveitis condition. Similarly, there was a next case with hypopyon, and this was also refractory to topical and systemic steroid. After going the AC tap and sending the sample for cytology, it was found that it was a case of microphyllary. So many times we may be misled with the pattern. That's why the cytology can aid us. But definitive diagnosis, if we suspect to be the infective origin, is with the help of the PCR from that aqueous sample. This was a case of endothelitis, just a ring separate um, infiltration in the cornea. And when we had sent the sample for analysis, this was a case of CMB anterior uveitis, which was positive in PCR. That's why and the treatment of CMB anterior uveitis definitely differs from the normal viral uveitis case, because here we have to start with ganciclovir, not just the acyclovir. That's why the PCR plays an important role in such scenario. After going further behind to the iris, we definitely have to look cautiously about the iris pattern, the nodules, if present or not. This can be a clue for the granulomatous uveitis, either the Kopis nodule which are present in the margin or the Busaka nodules which are present in the mid-stroma or burley nodule at the angles. So this will lead to a clue that these are the cases of tuberculosis, sarcoidosis, etc. Moreover, in the pattern we have to look whether there is atrophy or not. The patchy pattern of atrophy could be a clue for the herpes simplex infection or a diffuse pattern for the herpes zoster. Sometimes there can be heterochromia, and these are the clue towards the Fuchs uveitis. That's why iris plays an important role. Many of the time they may present with granuloma, like in this case with Hansen's disease. The granuloma at the angle can be detected not only clinically but also with the help of anterior segment OCT. The same applies for the the pupillary margin granuloma. And the synechia, how can we forget the synechia? Different type of uveitis may have a particular pattern of synechia, like this broad-based synechia occurring more than 3 clock hours continuously. This broad-based synechia again is a clue for the granulomatous uveitis, and the synechia which are present in the periphery, that is the peripheral anterior synechia, which we could see in this anterior segment OCT also. This is a clue for granulomatous uveitis, which we also call as a tent sepate PAS or peripheral anterior synechia, particularly in a case of sarcoidosis. If we move more further, the instrument that can be used to evaluate the pars plana region is the ultrasound biomicroscope. We don't have the facility of this in Nepal, but it's frequently done in Indian practices, and it's uh, it's definitely it is useful in case of intermediate uveitis. Now, vitreous plays a very important role, and the vitreous finding has to be cautiously noted. There could be cells, there could be clumps, there could be exudate, or there could be hemorrhage in a uveitis patient. These clumps they may sediment down as balls or lie down in the banking pattern as snow banks, and this can be visible with the help of ultrasonogram and further other investigations. This is the ultrasonography of a Shapu patient where we can see dense vitritis along with retinal detachment. Now this vitreous cells can be graded again with the help of OCT. The posterior vitreous cells sometimes may be missed, but this can be picked up by the STOCT. The upper picture is of the spectral domain OCT where you can see these vitreous cells, and the lower picture is the swept source or the SSOCT. You can see the vitreous cells along with a fungal ball. This was a case of Candida endophthalmitis. So the aqueous sample, the ocular sample that can be obtained for conducting PCR could be the sample from the conjunctiva, cornea, aqueous, vitreous, or even the subretinal fluid. And the site from where we can get the ample amount of sample is the vitreous. So what is this PCR? It's a method which just a xeroxing of a DNA segment so that you can identify the infective etiology of that disease. It could be a bacterial etiology, viral etiology, fungal etiology, or even a parasitic etiology. And initially there was a practice of nested PCR, but after that came the real-time PCR, where in fact you can do the quantification of the organism with the help not only identification but the quantification of the organism. Then came the comprehensive PCR. For a particular PCR, you have to introduce that particular primer. So you have to suspect which could be the organism. But in case of comprehensive PCR, it does sampling for a wide range of infective etiology or wide range of organism. And then came the deep genomic sequencing and finally the 16S microbiome analysis. This evaluates all the microbiome that are present in the vitreous cavity or in the ocular surface, and this is the latest technology that is being adopted. So let me share with you. This was one of our patients when I was working at India. This was a case of ARN, and when we underwent PCR from the vitreous sample, there it was positive for the herpes simplex virus, and the number of in fact, the viral load was 2 crore. With the treatment, you could see that there is peripheral clearing of the necrotic area, and the repeat PCR showed that it had decreased to 2 lakhs. That's why the PCR, the real-time PCR can detect and quantify the bacillary load in the real time. Thus, it is a good guide for us for the disease management. And this is one of the picture of the 16S microbiome analysis of the conjunctival surface, where all the organisms that are present in that conjunctiva can be identified. Now moving back towards the fundus, it will take a long hours if we go individually about the retinal disease that causes retinitis, or the disease of the retinal vessels causing retinal vasculitis, or the disease of choroid leading to choroiditis. Let us brief upon it. And what are the newer investigations, or what are the existing investigations that we can do to evaluate a case of posterior segment lesion? One of the simplest is the fundus autofluorescence. This was the fundus autofluorescence picture in a case of serpiginous choroiditis. This can be done in a fundus camera by changing the blue filter, or we are practicing this fundus autofluorescence using the OCT, the BAF mode in the OCT. These white areas are the areas showing the newer activities in the case of serpiginous choroiditis. So with the help of this fundus autofluorescence, no dye, just with the help of one picture, you can say that yes, the disease is reactivating. You need aggressive treatment at this time. Next is what we have been practicing at the FFA, or fundus fluorescence angiogram. The traditional FFA that we are using gives the view of 50 to 55 degree, but we are now blessed with sorry, but now we are blessed with the fundus wide field angiogram, which gives a wider view with 100 to 105 degree. So in fact, you can see that this is the area of activity that could have been missed with the normal FFA. But with the help of wide field angiogram, this area could be captured. And more better or more advanced is the ultra wide field angiogram, where in fact you can see the 200 degree of the retina. These are the area peripheral non-vascularization area which have been picked up with the UWFA. So how beautifully you can check the peripheral part of this patient with the help of WFA or UWFA. This can help you to add the laser in the far peripheral area also, and just to check whether there is prevalence of active lesion or vasculitis in the peripheral areas. Just an example, one more example of the utility of OCT. This was a patient who had a single nodular lesion at the level choroid. So we could in fact identify its height and width with the help of OCT. So in this tubercular granuloma, we could prove that this was a patient with tuberculosis. This choroidal granuloma was with tuberculosis with the help of PCR, and in fact identify its size. And with the treatment, this granuloma had resolved and the size has also decreased. Now, just looking at the retinal layers with the help of OCT may not be enough. You need to look further behind. You have to look behind at the choroidal level also. So this is the EDI, or enhanced depth imaging OCT that we have been practicing in our center, where you can measure the choroidal thickness. This was a case of acute anterior uveitis where the thickness was 401 micron. So may I repeat, it was a case of acute anterior uveitis. So choroidal thickness measurement may be important even in a case of anterior uveitis, not only intermediate or posterior uveitis. So this thickness it decreased with the treatment. So you can monitor whether your patient even with anterior uveitis is improving with your treatment or not with the help of the choroidal measurement using the EDI mode. And this was a patient with HLA-B27. And we also found that the vision, there was a significant relation with the visual presenting visual acuity and the choroidal thickness and the visual acuity after treatment with the decrease in the choroidal thickness. This is a simple form of OCT that we have been practicing to check the macular edemas, and more advanced could be the swab source OCT, where this was a patient with a VKH where you can see the multiple pockets of subretinal fluid and even the hyper-reflective content of this fluid with the thickened choroid is more visible in this swab source OCT. Now, at present, we have already been blessed with OCTA, and there are already 2 centers in Nepal which have this OCTA. It could be a good tool for the cases of uveitis, especially with the retinal vessels involved, because there can be decreased vascular capillary density and complexity both in the superficial and the deep vascular plexus in different kind of uveitis. And this was the OCTA in a patient with chronic occlusive retinal vasculitis, in a patient with Behçet's disease. Let me add on. This was how nicely the OCTA had picked up the CNVM, the choroidal neovascular membrane, in a patient with inflammatory vasculitis. But this this might need separate instrument, like you need to do as OCT, then fundus photo, separately FFA, ICG. That may not be possible all the time. So the latest advancement is with the presence of multimodal imaging. A single machine captures the image, whether it's the fundus photo, whether it's the FFA or the ICG or the OCTA, just with one machine, and you can actually look at the retinal layer or the choroidal layer with a single machine, and that's possible now with the multimodal imaging, like in this case with the serpiginous like choroiditis. Now this were about the ocular imaging techniques, but we have to focus on investigations also. Why investigations? Because we want to identify the presumed etiology of that condition, whether it's an autoimmune condition or an infectious etiology, so that we can obtain a diagnostic, prognostic information and thereby take a therapeutic directions for it. But your investigation should be targeted, because it may lead to you maybe somewhere, maybe anywhere, or maybe nowhere. That's why your mind should be clear what investigations you are going to do, for what reason, and what is your expectation. So before ordering investigations, the background or the history should be taken in the mind, along with the complete eye examination or the detailed ocular findings. Then you need to classify which kind of uveitis were we dealing with, because the etiology vary with the anatomical location of the uveitis. Then don't forget about the systemic evaluation. If the patient is having a mouth ulcer, a painless ulcer, and the patient gives history of staying abroad, this could be a case of syphilis. If the patient is giving the history of chest symptom and some skin rashes, it could be case of sarcoid. So in that case, you will better prefer HRCT of the chest or some blood investigation like serum ACE rather than going to a HLA typing. That's why These are the steps that we have to bear in mind before ordering any investigations. And routinely, we are practicing the HLE typing especially in cases of anterior uveitis, the non-granulomatous type, where we are frequently coming with the positive reports of HLA B27 and HLA B51 for the Behçet's disease. Now, let me summarize. What are the key issues that we have to look for? One thing is whether this particular uveitis is infective, is active or non-active, because we are not in a hurry to run after an inactive case. We have to counsel the patient that this is a disease which might have recurrence, which might get into a long-term management. That's why we have to act fast for the active disease. And the second clue is whether it's an infectious or a non-infectious etiology. Because if we think it to be infectious and if we hurry in starting oral steroid, that can lead to more complications than helping you in the management of the disease. So we are talking about the key issues. The first thing is active or inactive, infectious or non-infectious, and is it vision threatening or not? If it is a vision threatening, you don't have time. You don't have time to wait for it. Even if you are waiting for the investigations, you have to start your investigation. You have to start your treatment. I think there is some problem with the slide. Okay, and the complications
It's not
and
changing.
systemic disease. Yeah, now it's fine. Okay. So once you have addressed your key issues, whether this is a disease only located in the eye or this is a part of systemic disease, then only you can target your treatment. That's why the treatment modalities can just be topical in the form, can be topicals or the injectables or the systemic form of steroids. In addition to the cycloplegic agent, if it is a case of anterior uveitis, but main treatment is the treatment of cause, that we have to identify the cause with the help of the clinical examination and a detailed investigations. And the treatment, sometimes you may not be adequate with your steroids treatment. Okay, if we have to plan for long-term steroids, or if you are diagnosing some disease like VKS, sympathetic ophthalmia, or Behçet's disease, then it's better to start immunosuppressive agent from the initial part itself, because this will prevent the complications in those patients. That's why you have to be ready with the treatment with your immunosuppressive agent. Sometimes you may need to go higher up with the biological agents, and there are options of ionotropic for iontophoresis agent too. And in case of endophthalmitis or SHAPO or uveitis causing some other retinal complications, you might need to go ahead with the surgical management. So which steroid to prefer? Now that depends upon the permeability of that drug. So we usually prefer prednisolone acetate. This is basically for the anterior uveitis, where you have to treat with the topical eye drops, steroid eye drops. We usually prefer prednisolone acetate if the epithelium is intact, because this is a lipophilic drug. But if the epithelium is breached, then you have to go for a hydrophilic drug, and in that time you might need to go ahead with the prednisolone phosphate. We can see that the penetration of prednisolone acetate is far higher and better than that in compare with the dexamethasone and betamethasone. That's why this is the preferred drug if it is case of severe uveitis. Even in anterior uveitis, sometimes you may need to go ahead stepwise with the immunosuppressive drugs, and these are usually given in cases with the actually B27 uveitis patients, where you have to go side by side management with the methotrexate. When we move to intermediate uveitis treatment, we have the KAPLAND's module was there from long before, from more than a decade, but this has been modified, where the immunosuppressive agent that were at the topmost level has come down to number 3, and even in many cases now the immunosuppressive agent has been kept as the second line of management in a case of intermediate uveitis, because many of the time intermediate uveitis are idiopathic in origin with no associated infectious disease. But we have to be careful that this intermediate uveitis is not because of tuberculosis or with the infective etiology before starting the immunosuppressive agents. If you are coming across the cases with chronic macroedema or the refractive edema, then you have the options of implants like Ozurdex. This is the in situ photo with the Ozurdex implant, and this is the OCT picture of one of our patients where we have implanted, and the macroedema that was 367 micron had gone down to 288 micron with the implantation of Ozurdex. And there are some other options like fluocinolone implant, that is a Ritisort. Ganciclovir implant had been in use in the past but has not been that popular at present. Now, immunosuppressive agent, it depends upon the type of etiological type of disease, especially the non-infectious uveitis. They do better with the immunosuppressive agent because you can't keep the patient on with steroid for the longer duration. And there are a lot of choices of immunosuppressive agent. Out of this, the antimetabolites are the preferred one. And we, in our practice, we use methotrexate for the anterior type of uveitis, mycophenolate for the intermediate uveitis, and azathioprine for the posterior uveitis. We also have the experience with the biological agents, but before giving immunosuppressive agent, you have to counsel the patient about the side effects, and you need to check the blood parameters, especially the you have to look at for the bone marrow suppressions and the liver functions and the renal functions periodically. Sometimes you may not be able to get hold or the control of uveitis just with one immunosuppressive, and in that time the combination therapy is the preferred choice along with the steroids. So the newer practice is with the biological agent like infliximab or the adalimumab. We have outpatients of HLB27 who are on infliximab and some patients who are on adalimumab. The adalimumab is more easier because it's just a subcutaneous injection, but it's the drawback is its cost. Option is with the ocular antiphoresis, where in fact you can use a drug delivery system over the cornea and you can deliver the drug molecule into the into the aqueous. And this was one of the choice for the delivery of the dexamethasone for the anterior uveitis, but not much in a regular practice at present. And as I told, surgical management may be resolved for the cases with dense vitritis or retinal detachment, or it could be one of the method for the diagnostic approach, like to obtain the sample for the PCR analysis, etc. Now, just a recap, okay? Suppose you have a patient of pan-uveitis and that patient just had vasculitis. The differential diagnosis could be Behçet's, tuberculosis, or sarcoidosis. Or if the patient had retinitis or a choroiditis, then we have to think in the line of viral cause, tuberculosis, or Behçet's. Even a pan-uveitis patient, even they can present with hypopyon, and this in that condition we have to think for Behçet disease or endophthalmitis. Sometimes they may present with exudative RD, like in case of VKS or sympathetic ophthalmia. So we have to be broad in our thinking and analysis. Just with the modern fat KPs, the patient's modern fat KPs in the anterior segment examination, and if you have a closer look, you might find the choroidal nodules. This could be a case of tuberculosis, or there can be sometimes just subretinal abscess, and in fact, it could be proven as tuberculosis with the help of the PCR. So if we are suspecting sarcoid, what we are practicing is this serum angioconverting enzyme level and the serum calcium level along with the HRCT or the high resolution chest CT scan imaging along with the negative Montu test. Many of the times our patients are also going the bronchoalveolar lavage, and and their CD4 CD8 ratios are being checked to confirm it as a case of sarcoidosis. So let me come to the take home message. It's very difficult to get a definitive etiological diagnosis in a case of uveitis, but it's not that it's not achievable. It could be achieved with the support of a meticulous history, a detailed clinical examination, and a targeted investigations. The aim of treatment of uveitis is basically the control, because many of the time the cure of the disease might be difficult, and you have to counsel at the first presentation itself that you might have a recurrence of this disease. The PCR analysis and the immunobiomarker analysis would help us to reach to the etiology. But the main thing is your clinical suspicion and your pattern diagnosis is very important before sending this test. That's why even if we see this picture in a slit lamp examination, we should not give up that I don't know what is this, what it could be. It could be a case of ocular tuberculosis like this. We have to try till the end to reach the diagnosis so that we can give a targeted treatment. Thank you. And final message is stay safe and alert from this COVID outbreak.
Thank you so much, ma'am, for such a wonderful presentation. So there is some question, ma'am. So I'd like to begin with some of the question. And if anybody have the question, please you can unmute yourself and proceed to the question. Otherwise, I'm going to read one by one. I have rises on the text box. Okay, let me see. Okay, there is a first question from the Ajit Thakur sir. Sir, thank you so much for your question. He's asking for ma'am, can the microscopic examination of the AC tap or vitreous tap can yield anything where there is no PCR?
Yeah, definitely. The cytological examinations can help us even if there is no PCR, because if it is a case of viral uveitis, there will be more of lymphocyte. Okay, if it is a case of bacterial uveitis, there will be more of neutrophils. So good cytological examination will definitely help us giving a clue about the etiology.
Okay, thank you, ma'am. So I have seen a case of granuloma in iris and thoughts it is the some type of iris tumor. Can you kindly tell us how to differentiate the inflammatory granuloma with the tumor ones?
So you are asking me how to differentiate the inflammatory granuloma from the
Tumor
tumors?
ones, ma'am.
Okay,
Yes,
one thing, let me make clear that if we are suspecting ocular tumors, intraocular tumors, then it's better to avoid the invasive procedure, okay? Because that can, in fact, increase the your seedings of the carcinogenic cells. But if you think it's a case of, if you suspect it to be an inflammatory granuloma, then definitely, as I saw, it could be the presence of the cells, inflammatory cells like neutrophils or lymphocytes that can be detected. Moreover, they can, moreover, one better way to help in the diagnosis of a iris nodal suspected of tuberculosis, suspected of tumor is the imaging technique. In that case, you don't do a tap. You better go for the imaging technique like a CT scan, or more better is the MRI, and that MRI should be very thin sliced one. And not only
okay,
you are not
yes,
supposed
ma'am.
to we put a clinical diagnosis just based on one finding. You have to look in the system as a whole.
Okay, ma'am. Thank you. So there is another question as well. How do you suggest in the case of recurrent anterior non-granulomatous uveitis with all serological investigation negative and all the blood counts within normal limit?
Okay, serological investigations could not be that useful in the case of anterior non-granulomatous uveitis. Okay, in this case, we have to more focus on the HLA typing, because serological investigations basically means HIV and HIV, HCV for herpes, and for the syphilis. So if this comes negative, even if the patient has acute anterior non-granulomatous uveitis, look at the age of the patient, look at the posture of the patient, look at the laterality. If you suspect a case of actually B27 uveitis, they are using the ping pong pattern, okay, sometime in one eye, sometime in another eye. If you suspect to be the Fuchs, you can see the associated, which is also non-granulomatous uveitis. You can see the pattern of iris. So these you have to add on your investigation with your clinical findings to reach to a definitive diagnosis.
Okay, ma'am. Okay, thank you, ma'am. Another question from the Ananta sir. So he's asking for, ma'am, is there any evidence that COVID-19 causes the uveitis or anything, ma'am?
Yeah,
Intraocular
we had
infection, yes, ma'am.
No, we have
Yes,
we
ma'am.
had gone through the literatures, and we in fact have ourselves also written a review article on the effect of COVID-19 on eye. We found that the association of this COVID-19 virus is with the presence of AC2 receptors, which are basically present in the conjunctiva. Okay, and there have been reports of conjunctivitis as the first manifestation of COVID-19 patient that was even reported in an ophthalmologist, in anesthetics, and in few nurses of Europe. But we haven't till date come across any articles or any evidence saying that COVID-19 can cause uveitis. But I'm also really interested, and this is also one of the queries that I'm keeping in my mind, that it might cause, because uveitis can be caused by any of this disease in the body, so it might cause uveitis. We don't know yet, but let's wait for the time to answer this question.
Okay, ma'am. There is another question. Some here saying asking for the question, ma'am. What about the diflu
Yeah.
uveitis?
Yeah, it is also one of the steroids, but we have been practicing difluprednate in a case of uveitis with low intraocular pressure. Difluprednate usually help us to build up intraocular pressures also. That's why if we suspect a uveitis with hypotony, or a patient, a uveitic patient undergoing stage of atrophic bulbi before going to thysis bulbi, then this difluprednate are in use, but the sad part is that this is not available in Nepal.
Okay, ma'am. So, a patient with uveitis develop a cataract. When is it safe to remove it?
Okay, cataract is one of the expected complication in a patient with
Ma'am,
uveitis.
can you hear me, ma'am?
Yeah, yeah, I'm hearing you. You can hear me? Hello? I'm there. Can you hear me?
Yes, yes.
Okay, cataract
Yes,
is
ma'am.
one of the expected
Yes,
complication of
ma'am. Yes.
uveitis.
You are audible to us.
Yeah, okay. So cataract is one of the expected complication in a case of uveitis, but we need to do cataract surgery, but we have to wait for the right time. Okay, usually we wait until it's quiet for 2 to 3 months, and before doing a cataract surgery, we have to take extra precautions like starting oral steroid 3 to 4 days prior to surgery, and then continuing it with the next 2 weeks. We expect more inflammation in a uveitic patient undergoing cataract surgery. That's why we have to continue the steroids even after the cataract surgery. But identifying the right time is very important. Suppose it's a case of phacoanaphylatic cataract. The lens itself is creating the uveitis. Then in that condition, we might need to go cataract surgery at early stage. But usually, until the eye is quiet for at least 2 to 3 months, we don't hurry for a cataract surgery.
So, I did answer most of the questions. So, please, if anybody has a question, you can unmute yourself and ask the question. So before that, there is a one question. Uh, Dayanand Kumar sir asking for what are the treatment plan of recurrent anterior uveitis plus vitritis in non-case of leukemia patient?
Okay, this leukemia patient are immunocompromised. So in such conditions, we have to very cautiously look into it. We plan to avoid the oral medications from our side, and if needed, for anti-uveitis, you can like simply go ahead with the topical steroids. But if needed for the vitritis, you can go ahead with the intravitreal injections or with the vitreous implant, steroid implants. But we tend to avoid oral steroids in such conditions, oral steroids and immunosuppressants in such conditions.
Okay, so I guess we have done most of the slides, ma'am.